Well, there's been a lot of discussion recently about when to do an axillary dissection. Generally speaking, the research shows that if we get 10 lymph nodes from an axilla dissection, that would be an adequate number of lymph nodes to be removed. We know that if you go in there under the arm and take out a lot of nodes, you're going to be increasing the risk of complications. For example, lymphedema. There's been a trial recently came out that was done by the American College of Surgeons called the American College of Surgeons Z11 trial that basically looked at when should you do an axilla dissection. So up until that trial came out, if we did a lumpectomy or a mastectomy and we did a sentinel lymph node biopsy and we tested that lymph node during the surgery with a frozen section result, if that came back showing cancer in the lymph node, then we would go ahead straight away and do an axilla dissection. The Z11 trial showed that if the patient was having a lumpectomy and if she was going to be going on to have radiation treatment and or chemotherapy and hormonal therapy, it studied two groups of patients. Some patients that had an axilla dissection with a positive lymph node, 1 or 2 positive nodes, and people who didn't have an axilla dissection, and it showed there was no difference in the chance of the cancer coming back under the arm and the survival of the patient. So if we're doing a sentinel lymph node biopsy on somebody who's going to be falling into that category, which is having a lumpectomy, most likely having radiation, chemotherapy, and or hormonal therapy, we don't do frozen sections on those nodes anymore because we know that there's no benefit in doing an axilla dissection. So it's decreased the numbers of axilla dissections that we do, which is decreasing the complications, including decreasing the incidence of lymphedema, which is swelling of the arm after axilla surgery, often made more likely to happen with radiation as well. So we're doing less aggressive surgery in these patients.